The study by Munareto and his group of co-authors is a very interesting one, as it brings to the table a different approach of hybrid procedures to treat standalone atrial fibrillation. Their approach is a unilateral approach using a unidirectional energy source, as opposed to the bilateral approach with bipolar radiofrequency ablation. The study, however, raised some important questions and maybe some concerns associated with it that I hope we will have some time to discuss. The study is designed in a way that it's an observational prospective study that's powered to have about 90 to 100 patients at a year in order to basically compare to historical data from the catheter ablation world with some significant margins. This begs the questions whether this is the right design of a study, as we always strive to perform studies that will result in what we call the level A evidence, which is a prospective randomized study where we truly compare two technologies across the same patient population. In my mind, the best design for this study would be a catheter ablation arm, hybrid procedure arm, and a surgical ablation involving a maze procedure on the heart-lung machine in order to ascertain the rhythm outcome as well as the safety outcomes of such technologies. The obstacles for such studies are associated in a couple of major, what I call the hard stops. One is the ability to convince electrophysiologists to participate in a study that one arm is surgery only, and the second is being the competency of surgeons performing the maze procedure the way it is supposed to be performed in order to maximize the results, which in good hands in standalone procedure in non-paroxysmal patients result in a close to 90% success rate of medication in 2 years. I think that this study actually is an important one. On one hand, we know that the technology that was used is not really 100% producing transmural lesions. On the other hand, the results reported are somewhat impressive, which begs the questions whether transmurality is important. Now, transmurality is a histological, pathological definition and not an electrophysiological definition, so it remains to be seen what's the long-term results of such a study will show us. As we know from the catheter ablation world, the results of catheter ablation for atrial fibrillation at 1 year are reasonable. However, there is a significant drop when we go to the second and the third and the fourth year following ablation, which basically leave us with about 25% success rate at 5 years for catheter ablation, even though at 1 year that same series of patients showed some promising results. So this is a very interesting question. I think that there is not much interest in developing new technologies for surgery because the market seems to be small. Having said that, there is some movement in understanding what would be the role of hybrid procedures that in turn may bring some enthusiasm into the industry so we can have new devices. There needs to be a paradigm shift with regard to what devices are doing by looking into the tissue per se and rather than what the device is delivering. In other words, the temperature controlled technologies that we are currently using is really not the right answer, as we really need to understand what's the tissue temperature while we are ablating, whether freezing or burning. And I think that's the next step that is really required in order to break the ice and get excellent results on beating heart. So, you know, in cardiovascular diseases, we are moving forward and try to have significant discussions about patient selection across the aisle. In other words, between cardiologists and cardiac surgeons in order to maximize care delivery. It works extremely well in the TAVI world, where, you know, for the valve delivery systems. It works to some extent in coronary revascularization. It doesn't work so well in most centers when it comes to AF ablation. So I think the concept of the hybrid procedure is the most important one, rather than right now the delivery of what the procedure is being performed. Because by having those discussions around studies and outside studies between electrophysiologists and surgeons, I hope we can finally create an algorithm where everything has a place. Catheter ablation, hybrid procedure where you do catheter ablation and surgical procedure together or in stage, and the standalone MACE procedure on pump for patients. So we'll have a very broad algorithm to treat all patients and deliver better outcome.